Thank you very much, Rohit and Entor Pharma for getting me over here. Uh, Prediction that Siddharth made. Going a few steps further, a few decades down the line, with the antenatal interventions and AI, you will be able to design children without myopia. But until then, we have myopic children whom we need to intervene and reduce their progression from developing pathological myopia, which is associated with multiple comorbidities. Here I'm going to describe some advances and unresolved challenges in the use of this drug. I have no declaration regarding conflict of interest. I think the establishment of the role of atropine in treatment of myopia was done through these studies. In 2015, it was quite well understood by us that using low dose atropine is effective, safe, and has lowest rebound myopia, giving very good intervention to reduce the progression of myopia in children. We had our first product, low dose atropine, available in India in 2017, following which more and more brands are now available, and most people managing children with progressive myopia are using it. Uh, until recently, there were concerns from Pediatric Eye Disease Investigator Group regarding the efficacy, but last month it was quite cleared, and FDA has approved low-dose atropine in US for childhood myopia progression. So that's one update. Now, in 2019, there were consensus statements and guidelines made for Indian children, and they, by and large, still hold true when we treat patients with myopia. Children who age between 5 to 14 years, who have simple myopia, uh, they do qualify for routine use of low-dose atropine. There is, of course, no strong contraindication or absolute contraindication available for children to be below this age or beyond this age. Those children who have a progression of 0.5 diopter per year or more in the previous year, of course, which is not extremely predictive of the next year's progression, but right now that is the preferred practice pattern. You look at the previous year's progression, and if you find there is 0.5 or more progression, you may like to start the drug. However, this cutoff can be lowered at this point in time using the age of the child or a strong family history, which may be predictive of the SNPs which Siddharth was talking about. Maybe that's why in pre-myopia studies of ATOM 3 or LAMP 2, people are talking about the family history in choosing the patients for pre-myopia management. 6 monthly follow-up is what is recommended at this point in time, those patients who are on low-dose atropine. And how do you define a non-responder or suboptimal responder? Someone who responds with less than 50% efficacy in reducing the progression of myopia uh, in the first year. The non-responders, you may like to increase the frequency or the concentration of the drug. So there are definitely situations where this drug either does not work at all or you have suboptimal response. Nearly 15 to 20% children, normal children, so to say, in ATOM 2 study did not respond optimally. Maybe in future again, this we would be able to identify much better. Patients who have lasered ROP, there was an RCT poster in American Academy of Ophthalmology Conference 2018, which never got published. It was a placebo-controlled trial, and there was no effectiveness of the drug in compared to the placebo. And pathological myopes like JXLR, pigmentary retinopathies, or patients with Stickler syndrome, they may not respond optimally or may have non-response to this drug. So when you confront such situation of non-response, how can you make the drug more effective? Is either you increase the frequency or make it daytime, for which there is no strong level of evidence available for this recommendation. But recommendation is strong for increasing the concentration of the drug. Even in ATOM 2 study, there was an increasing efficiency of the drug, efficacy of the drug with increased concentration of the drug, and it was more cleared with lower concentrations like 0.01, 0.25 and 0.5 in LAMP studies. A recent publication by Rohit Saxena group from AIMS. It's a randomized control trial where atropine 0.05% was found to be around 8-10% more effective than 0.01%. And Indian FDA has approved 0.05% formulation, which is awaiting commercialization from Antod Pharma. This was the poster we presented in this conference, and we found around 25% of our patients using 0.05% atropine were intolerant and had to discontinue the use of 0.05% in favor of 0.01% because of the blurring of the vision, and we realized it was associated strongly with their reduced near point of accommodation. That means farther near point of accommodation. If the 0.05% also does not work, or if you don't have access to 0.05% or you don't want to start 0.05%, then you may consider using it with defocus lenses. Again, there are 3 studies available, of which one is randomized control trial, one that was presented last month at the AIOS conference, again coming from Rohit Saxena's group, where DIMS was found to be superior versus only DIMS or defocus lens versus only atropine. So combination was certainly superior. This is another group where combination with defocus lens was superior to orthokeratology, which was even better than single vision lenses. So combination certainly seems to make more sense when the progression is not well controlled. Also, there is a study from Dr. Jitendra Jethani which showed in patients who are not responding well to low dose atropine, you may add defocus lens rather than replace the defocus lens to improve your effect. The safety of using combination therapy is proven. It seems it does not have any clinical detectable effect. Of course, time will tell us over the years whether there is any significant side effect of these drugs. The good news is there are more and more products available in Indian market. Right now there are 5 defocus lenses easily available to us. Each one of the newer lens has higher volume of myopic defocus, and it seems there is an increasing efficacy with increased volume of myopic defocus, and the cost has significantly reduced from 10,000 to, in this particular conference, a new lens which I saw called MyoSol lens, myopia solution lens, has gone down to 3,500 rupees, making it accessible. This paper was presented in this conference from us, and we found the combination of defocus lens along with low dose atropine was giving whooping 93% reduction in the progression of myopia in a small sample in an unrandomized method. In the past studies, it was found that when used for long years, many years, the low dose atropine is safe on retina. Also, a recent study on intermittent exotropia showed that use of low dose atropine does not, because it reduces accommodation in children, accommodative convergence may go down, but it does not increase the likelihood of the child requiring intervention for decompensation. In the past, we have published sometimes after surgery for intermittent exotropia, when low dose atropine is used, it may cause convergence excess type of esotropia, and prompt discontinuation of the drug may be associated with realignment of the patient and restoration of binocular vision and 3D vision. At this point in time, there are only 2 concerns I have for long-term use of low dose atropine. Number one, in some patients it may develop ocular allergy, which is quite reversible once you stop the drug. A bigger concern is the role of rebound myopia. Again, Dr. Rohit Saxena's study is what I have showed over here, and Dr. Yair Morad's study. Both of them have shown that you might like to taper the drug rather than suddenly discontinue the drug. In our survey of pediatric eye surgeons of Mumbai, we realized nearly 85% of our pediatric eye surgeons in our city are not suddenly discontinuing, they are tapering the drug. And based on the data that we have collected in our RCT so far, it seems you might like to reduce the drug by 1 day per week per month, which is what Dr. Yair Morad had suggested. Last but not least, how to use atropine for prevention of myopia. We are eagerly waiting for ATOM-3 study. Meanwhile, LAMP2 is already published, which has shown that using low dose atropine once at bedtime can significantly reduce the incidence of myopia, especially if you include the high risk groups taking one of the parents having myopia of more than 3 diopter or sibling having progressive myopia, you might reduce the unnecessary treatment. So my key take home points for you is you may consider use of 0.01% atropine eye drops routinely for all progressive childhood myopia not controlled with lifestyle modifications. Age is practically no bar. However, less than 2 years of age, you should be concerned because they have a developing retina, they have a developing ocular system. You might like to increase the concentration to 0.05 if near point of accommodation is less than 8 centimeter. It is best used in combination with defocus lenses. In fact, right now we believe defocus lenses are more effective than just low dose atropine. Minimum use should be 2 years and should never be suddenly stopped at any point in time. Close monitoring should be done as close as 2 to 3 months when you switch off low dose atropine. And finally, you should consider low dose atropine for pre-myopes between 4 to 9 years of age, which may become preferred practice pattern, especially once we have good AIs available to predict who are at high risk. Thank you very much for your kind attention.
Thank you, Dr. Mihir.